Welcome back to another episode of FMGE Recall Rush. Today we'll be going through orthopedics PYQs from the past 5 years. You will have 25 questions and 5 seconds to answer each question, which will be followed by an explanation of the correct answer. We are curious to know how many questions you get right. Let us know in the comments. Here's the first question on your screen now.
Question 1. An elderly patient with the following deformity was brought to the OPD. What is the most probable diagnosis? Here are the options. A. Rickets. B. Osteomyelitis. C. Osteoarthritis. D. Rheumatoid arthritis. And the correct answer is D. Rheumatoid arthritis. Here's the explanation.
Clinical features. The main clinical feature is symmetrical involvement of small joints. Small joints means hand joints. Suppose right side index finger is involved, left side index finger is also involved. That is called symmetrical joint involvement of small joints, especially hand and feet. Joints that are, this is so important, dear friends. Kindly take down. I made it so simple for you. These are the joints that are involved in decreasing frequency. Decreasing frequency. The first joint, the most commonly involved joint that is involved in case of rheumatoid arthritis is metacarpophalangeal joint. It is metacarpophalangeal joint. The second joint is involved is wrist joint. The third joint that is involved is proximal interphalangeal joint. Fourth joint that is commonly involved is knee joint. Fifth joint that is commonly involved is metatarsophalangeal joint, foot. Then your shoulder, then your ankle, then your cervical spine, then your hip joint, then your elbow joint, lastly temporomandibular joint. Okay. So the most common joint involved is metacarpophalangeal joint, wrist joint, proximal interphalangeal joint, knee joint, metatarsophalangeal joint, shoulder joint, ankle joint, cervical spine. This point is very important. That's why I am stressing again. Cervical spine, hip, elbow, then temporomandibular joints. These are the joints that are involved. Okay. Only in the whole spine, we have 33 vertebrae that everyone knows. The whole spine, only cervical spine is involved. Your rheumatoid arthritis will not cause involvement of the lumbar, thoracic or sacral vertebrae. So, only cervical spine is involved. That's why low backache, when somebody presents with backache, that is not a case of rheumatoid arthritis. It's not a feature. Okay. They can very rarely present with neck pain. Never with low backache. Somebody is presenting with low backache, you are dealing some other cases. It is not rheumatoid arthritis. That's the point I want to stress. So they can ask this as an MCQ. In the vertebra, which part is involved in rheumatoid arthritis? Only cervical vertebra. Only cervical vertebra. Look at the next golden point. Several times repeated question in AIMS. Joints that is not involved in rheumatoid arthritis. Distal interphalangeal joint, sacroiliac joint. Please take down very specially, put a box and 2 stars. Joint not involved in rheumatoid arthritis. Distal interphalangeal joint, sacroiliac joint. Okay. Then clinically they can have rheumatoid nodules. Look at the diagram. You see, you are able to see knots like thing. Okay. Here the Olecranon. So they are rheumatoid nodules. Classically, they are present only in 25% of cases, not in all cases, rheumatoid nodules. And it's, to be very frank, it's more common in fair-skinned individuals. That's Western world. Our country is very rare. I had seen very few cases. Okay, in Western world, probably a common thing. Present 25%, commonly seen on Olecranon aspect. You see here, Olecranon aspect of the elbow, Achilles tendon, extensor aspect of the hand and foot. So it is seen only in extensor aspects. Very interestingly, one practical point I want to stress is, see, you all know pretty well that the drug usually we will give for rheumatoid arthritis, a disease modifying anti-rheumatoid which we give is methotrexate. So, very interestingly, when you put the patient on methotrexate, rheumatoid nodule sizes are increasing. That's one study they had. So methotrexate treatment can cause increase in nodulosis, increase in size of the nodulosis. So something tells my mind, they may ask this as a question. Okay, the rheumatoid nodule size is increased in one of the following by one of the following drugs. They'll give all the drugs that are used for rheumatoid arthritis: hydroxychloroquine, methotrexate, adalimumab, tocilizumab, anakinra, something like that. So the answer is
Question 2. A 20-year-old patient presents with painful swelling in the middle finger around the proximal phalanx. An X-ray was done, and it is shown below. What is the most likely diagnosis? Here are the options. A. Osteosarcoma. B. Ewing's sarcoma. C. Osteoclastoma. D. Enchondroma. And the correct answer is D. Enchondroma. Here's the explanation.
tumor. Enchondroma. This chondroma is otherwise called enchondroma. Enchondroma. Okay. This is a benign tumor which arises from the hyaline cartilage. This arises from the hyaline cartilage. Okay. This arises from the hyaline cartilage. It causes destruction of the cancellous bone. That's why the name N. N means inside. Exo means outside. Exostosis or osteochondroma, which arises from the cortical bone outside. It's shown outside the bone. But this here, you see the destruction is happening inside the bone. That is in the cancellous bone. That's why since inside it's called enchondroma. This is called enchondroma, and it arises from the hyaline cartilage. The peak age of incidence, don't take down this 50, no. This is the peak age of incidence 10 to 30 years. 10 to 30 years. Okay. It can happen anywhere in the body since it's a hyaline cartilage tumor. Most commonly, this is seen in phalanges of the hand. Phalanx of the hand, especially little finger. Especially little finger. 1000 times repeated MCQ. Please take down. Once in a DependB question, I remember very strongly, they had asked a question, most common bone tumor of hand and foot. This was the question. Answer is enchondroma. So, this is the most common tumor that is seen in hand and foot. Okay, enchondroma, that is called chondroma. Right. See, clinical presentation, 99% it is symptomless, no symptoms at all, asymptomatic. Sometimes this can present to you with pathological fracture. This can present to you with pathological fracture. Okay. So, this is the clinical presentation. Very rarely it can, fracture means pain, swelling. Okay. So, it presents as pathological fracture. Diagnosis. And one more point I want to tell you, enchondroma, this what we are discussing is solitary enchondroma. Sometimes there is a condition called multiple enchondromatosis. Multiple enchondromatosis. Multiple enchondromatosis. Chondromatosis. Enchondromatosis. The answer is given in all orthopedic textbooks. Already we had studied in pathology, Robbins also. This is called, multiple enchondromatosis is called Oler's disease. Oler's disease. Okay. Oler's disease. Okay. Multiple enchondromatosis is called Oler's disease. Oler's disease is good or bad? Very bad. Why? 40% of them will undergo malignancy by 40 years of age. That's what the book says. Oler's disease, multiple enchondromatosis, high chance of going for malignant change. Chondrosarcoma, high chance of going for malignant change. Solitary enchondroma itself has very potential to undergo malignancy. When it is multiple enchondromatosis, otherwise called Oler's disease, very high chance of going for malignancy. That's what book says, no? 40% out of 100 cases, 40 cases will go for malignant change. So, that is Oler's disease. If with multiple enchondromatosis, when the patients are associated with facial hemangioma, okay, enchondromatosis with hemangioma of the face, hemangiomas of the face, Okay, it is called Maffucci syndrome. Okay, Maffucci syndrome. Okay, very important. So there are two variants of enchondroma. Simple enchondroma is one entity. Multiple enchondromatosis is called Olier's disease. Enchondromatosis with facial hemangiomas, they are called Maffucci syndrome. Okay, right. Then how to diagnose? Obviously our X-ray, when you take an X-ray, it will show you an expanded lytic lesion with wisp of calcification, very pathognomonic. You look at here, an expanded lytic lesion, we are able to see expanded osteolytic lesion, okay, with wisp of calcification inside it. See, you are able to see small, this is calcifications. Okay, calcification, this very pathognomonic. And one more thing, I will erase and I will show you, just to follow. See, it is expanded, but nowhere you are seeing breaching of the cortex. There is no breakage in the cortex. See, the cortex is completely intact. Cortex is completely intact. There is no breakage of the cortex. This again is very characteristic.
Question 4. A young patient presented to the emergency department with pain and swelling of the right knee. Plain radiograph shows the following finding. What is the best treatment for the given condition? Here are the options. A. Tension band wiring with K wires. B. Tension band wiring with cancellous screws. C. Cylinder cast. D. Patellectomy. And the correct answer is A. Tension band wiring with K wires. Here's the explanation.
Once we have diagnosed a case of fracture patella, how to go ahead with the treatment of fracture patella? Very simple. You assess whether it's a displaced or undisplaced one. If it's undisplaced fracture patella, as I told you, no, if it is less than 2, okay, this is the landmark, less than 2 millimeter of gap. Okay, it's called undisplaced. If it's undisplaced fracture patella, treatment of choice is conservative. Conservative means just you are giving a cylinder cast, that is otherwise called a tube cast. Okay, tube casting, that is the treatment of choice. How to put a tube cast? Take a POP from middle of the thigh to middle of the leg. You are immobilizing the knee joint alone. That's called tube cast. For a period of 6 to 8 weeks is enough. If it's a displaced fracture patella, that is gap is more than 2 millimeters, it needs fixation, it needs surgery. You cannot treat conservatively. When you treat conservatively, it will go for non-union. So, it needs fixation. What is the surgery of choice? What for transverse? If it is a transverse fracture patella, if it is a displaced on transverse fracture patella, the treatment of choice is the time-honored, okay, time-honored tension band wiring. Tension band, TBW, tension band wiring. Okay, that's called tension band wiring. The full name of that is called Martin's circumferential tension band wiring.
Question 5. A 6-month-old child is brought to the OPD with a deformity as shown in the image given below. Which of the following is your line of management? Here are the options. A. Manipulation and cast. B. Posteromedial soft tissue release. C. Triple arthrodesis. D. Evans procedure. And the correct answer is A. Manipulation and cast. Here's the explanation.
Treatment of CTEV. When we finish this treatment, this topic is over, dear friends. Okay, when we finish this, 3, look at that. Don't take down this as like that. Just follow my speech. I will write here and there. You take that notes. Okay, I'll make it so simple for you. When you read the book for first time, he is confused. Is that so simple? I'll make it simple for you. Treatment should begin as soon as birth. Please strike out this first vehicle. As soon as birth. Okay. My professor had taught me that a CTEV baby is there. You have delivered a CTEV baby. After the baby had drunk the first milk from the mother, start treating. Okay. So it should be treated as soon as birth. Strike away these first few weeks of life. And order of correction is very important, dear friends. In CTEV, just like that, you should not manipulate. There is a method which should be corrected first, which should be corrected last. They are asking this several times in our All India. Okay, you see that. Forefoot adduction should be corrected first. Inversion should be corrected second. Equinus should be corrected last. What is the order of correction? Forefoot adduction first, inversion next, equinus last. I repeat, this is a golden point. That's why I am telling it for the third time. Forefoot adduction first, inversion next, equinus last. This is the order of correction, and this method of correction is called Ponseti's method. Okay, this is called Ponseti's method. This is called Ponseti's method of correction. So you correct forefoot adduction, inversion, equinus, just give a below knee POP cast. That is called Ponseti correction. Okay, when you correct serially, that is called Kite's method. That's not needed. This is Ponseti correction. This is Ponseti's method. There is one more method which is called Kite's method. Okay, Kite's method of correction. Okay, Ponseti is very popular. Okay, Ponseti gives a better result. Okay, use minimum force in correction and gives, you should not be very violent. Okay, it should give a very minimal gentle force. That is why as soon as birth, no, I said no, from birth till 8 weeks, manipulation by mother. That is manipulation by mother. Manipulation by mother. Okay, from birth till 8 weeks, manipulation by mother. No surgery, no heroic procedure. What is the manipulation by mother? What she is doing? Orthopedician or physiotherapist will teach her how to manipulate, how to correct a CTEV. That is forefoot adduction first, inversion next, equinus last. And she has to do that. And since the very first week we won't apply POP because the skin is very flimsy, very thin in a newborn. When you put a POP, it can cause blisters. Okay, so for first 2 weeks we won't put POP, nothing, just manipulation by the mother. After that, it will come to an orthopedician. I will correct and put a below knee POP by the same method, Ponseti's method.
Question 6. A young male who had a road traffic accident is brought to the emergency department. His left leg is shortened, internally rotated, and adducted. On examination, femoral artery pulsation is not felt. A plain radiograph of his was taken, which is shown below. What is your diagnosis? Here are the options. A. Intertrochanteric fracture of the femur. B. Fracture neck of femur with injury to femoral vessels. C. Anterior dislocation of hip with femoral artery injury. D. Posterior dislocation of hip. And the correct answer is D. Posterior dislocation of hip. Here's the explanation.
About posterior dislocation hip. Posterior dislocation hip is the most common type of dislocation. What is the mechanism of injury? What is the mode of injury? Look at the first line. Axial force applied to a flexed, adducted, internally rotated hip. When an axial force is applied to an flexed, adducted, internally rotated hip, it will end up in posterior dislocation hip. The classical example is our dashboard injury. You're traveling in a car, not wearing a seat belt, collision has happened, your knee joint will go and dash against the dashboard, you'll develop posterior dislocation hip. Okay, look at the diagram. So this is a posterior dislocation hip. And whenever any dislocation is shoulder dislocation or hip dislocation, attitude of the affected limb is very important. We had seen in shoulder dislocation, anterior shoulder dislocation, the upper limb, arm is extended, abducted, externally rotated. That's what we had seen. So like that, the classical attitude of posterior dislocation hip is, look at this affected side. Okay, it is flexion at the hip, adduction and internal rotation. So it is flexion, adduction, internal rotation. So this is the classical attitude of the affected limb in posterior dislocation hip. If it is an anterior dislocation hip, it is flexion, abduction, external rotation. Just by looking at the individual, the suffering individual, we can come to a conclusion what type of dislocation it is. So I repeat once again, in posterior dislocation hip, the hip is flexed, adducted, internally rotated. In anterior dislocation hip, the hip is flexed, abducted, externally rotated. In central dislocation hip, you can't see any change in the attitude. It looks near normal. Okay, good. Now, marked shortening of the limb with gross restriction of all hip movements. Because obvious, dear friends, it's very obvious. Head is out of the socket. How can there be a smooth movement of the hip joint? Okay, so all the movements are restricted, and on the affected side, the limb is shortened. Okay, and classically, vascular sign of Noreth is positive. Please focus. Concentrate. Please take notes. Vascular sign of Noreth. What do you mean by vascular sign of Noreth positive? Let me explain it first. Okay. Make the patient in supine position. Palpate for the femoral artery pulsation. Where is femoral artery pulsation felt? Mid-inguinal point. You know very well where is the mid-inguinal point. Anterosuperior spine, pubic symphysis, midpoint is the mid-inguinal point. That's the mid-inguinal point. Just below that is your femoral pulse. Normally in all of us, when you palpate on both sides, easily the femoral artery pulsation is felt because when you press underneath the femoral artery, your head and neck is there. A bony thing is there. Head and neck is there. So that a bony support is there. So when I press, easily I can palpate the pulse. Suppose a bony support is not there. When you press over the vessel is pushed down, so you can't palpate that easily a pulse. So the pulse can be feeble or absent. It's not normal. Feeble or absent. So on palpation, one side is okay, another side it's feeble or absent. It is called positive vascular sign of Noreth.
Question 8. A patient presents with hip pain and true shortening of the limb which was diagnosed as tuberculosis of the hip. Which stage of the disease is he currently in? Here are the options. A. Stage of early arthritis. B. Stage of synovitis. C. Stage of late arthritis. D. Stage of pathological dislocation. And the correct answer is C. Stage of late arthritis. Here's the explanation.
Once you are not treating, you'll go for the third stage. Third stage is called stage of late arthritis. Same as early arthritis, but all the things are more pronounced. That's all. Stage of late arthritis. Significant destruction of the articular cartilage. Marked flexion, adduction, internal rotation. True shortening. And gross restriction of movement in all directions, more than 50%. X-ray shows significant subchondral erosion and destruction. This is stage 3.
Question 9. A patient after sleeping the whole night with the arm hanging over the back of the chair, wakes up with the inability to extend his wrist. This is due to, here are the options. A. Neurotomesis. B. Neurolysis. C. Axonotmesis. D. Neuropraxia. And the correct answer is D. Neuropraxia. Here's the explanation.
Yeah, praxia means stretching. Praxia means stretching. You see, this is a transient episode of complete motor with a little sensory paralysis. Complete motor. See, each and every point you should take down, dear friends. There is no shortcut in this. You should take down. It is a transient episode of complete motor with a little sensory paralysis. Temporary physiological disruption of the nerve impulse. That means there is no anatomical damage. Just a stretching, there is no anatomical damage. That's what is meaning, physiological disruption of nerve impulse. Complete recovery is the rule. When you just do some physiotherapy and give a rest and physiotherapy, complete recovery is the rule. This is the commonest palsy we are encountering in orthopedics, post-surgical, right? It is thought to be local reaction to ischemia that results in ion-induced conduction blockade. Ion-induced conduction blockade. That's the pathogenesis. Since there is no anatomical disruption, no Wallerian degeneration. When Wallerian degeneration is there, there is no question of Tinel sign. When there is no degeneration, how regeneration will happen? Tinel sign is a sign of regeneration. There is no degeneration means no need of regeneration. Nothing is lost. It's just physiological. That's why I am using the word physiological disruption. That means no anatomical damage. Okay. Recovery begins within 2 to 3 weeks. Complete recovery rule is 8 weeks. By 8th week, 100% you will get a complete recovery. A very good example is crutch palsy, Saturday night palsy. Okay, you see here, this is the schematic diagram. Nowhere there is some interruption, some damage, nothing has happened. Okay, it's very clean. It is physiological, just here stretching, that's all. Another good example I can say is tourniquet palsy. As a house surgeon you would have seen, no? For forearm surgeries you will apply tourniquet. This is compressing. It can cause local ischemia to the nerve. When you remove, no, patient may be having a sort of radial nerve, like a wrist drop, radial nerve palsy will be there. Just it will recover in 6 to 8 weeks. This is an example of neuropraxia. Very, very important.
Question 10. A young man is brought to the emergency department following a road traffic accident. He was driving the car when the accident occurred. On examination, it is noted that the injured leg is shortened. The image of the pelvis radiograph is shown below. Which of the following nerve is most commonly in the given condition? Here are the options. A. Sciatic nerve. B. Posterior femoral cutaneous nerve. C. Inferior gluteal nerve. D. Superior gluteal nerve. And the correct answer is A. Sciatic nerve. Here's the explanation.
Complications of hip dislocation. The main complication is sciatic nerve. Posterior dislocation hip means sciatic nerve injury. That two common peroneal division should come to your thing. So posterior dislocation hip, the main complications of foot drop because of common peroneal nerve injury, that is broadly sciatic nerve injury.
Question 11. A 30-year-old male comes to the casualty with a history of a road traffic accident and left hip pain. On examination, the leg is in flexion, abduction, and external rotation deformity, with lengthening of the limb. What is the most likely diagnosis? Here are the options. A. Posterior dislocation of hip. B. Anterior dislocation of hip. C. Intertrochanteric fracture. D. Neck of femur fracture. And the correct answer is B. Anterior dislocation of hip. Here's the explanation.
On to the next dislocation hip, anterior dislocation hip. We have seen posterior, that's the main thing. This is a very, very short topic. You look at the first point, very rare. I told you, the most common is posterior dislocation hip. It's very rare. Rarest, if they ask, it is central dislocation hip. It's much rarer than anterior, okay? Right. Coming to mechanism of injury, what is the mechanism we have seen in posterior dislocation hip? It's very simple, no? The dashboard injury. The hip is flexed, hip is adducted and internally rotated. Then it is causing a posterior dislocation hip. Exact opposite to that. You see, a forced abduction, lateral rotation of hip causes anterior dislocation. This needs much more violent trauma than dashboard injury. So, example, air crash injury. Probably I am telling you, when you compare this posterior dislocation hip with an anterior dislocation hip, posterior dislocation hip is a mediocre, probably, okay, not that rich guy. This anterior dislocation is air crash, man. It's very costly dislocation, I believe. Okay, and clinically there will be limb lengthening. In posterior dislocation hip, we saw a limb shortening. Here there is limb lengthening. In anterior dislocation hip, the most common nerve that is damaged is femoral nerve. In posterior dislocation hip, we have seen the most common nerve, that is sciatic nerve, the two peroneal division. Okay, common peroneal nerve, foot drop. Here it is femoral nerve, that's very commonly involved. There in posterior dislocation hip, we said there is a positive vascular sign of Narath. Here, vascular sign of Narath is negative. That means normal femoral pulse is felt. That's the meaning, because anterior dislocation means just beneath the femoral artery, that bony support is available. In posterior dislocation, it's not there.
Question 12. The fracture seen in the X-ray given below is. Here are the options. A. Galeazzi's fracture. B. Montague fracture. C. Smith's fracture. D. Colles fracture. And the correct answer is A. Galeazzi's fracture. Here's the explanation.
We'll move on to the next topic, a very important topic, Galeazzi fracture. Like Montague, this is the next named fracture, Galeazzi. First we should know, like Montague, we should know what is the definition of Galeazzi. Okay, Montague, we know the definition. It is fracture upper third ulna with radial head subluxation. Like that, Galeazzi fracture is defined as fracture lower radius with distal radio-ulnar joint. Dislocation of the with distal radio-ulnar joint subluxation. Okay, subluxation. So, what is Galeazzi fracture? Galeazzi fracture is fracture lower third of the radius with subluxation of the distal radio-ulnar joint. That's the definition, exact opposite to the Monteggia. I will show you in the diagram. You see, dear friends, the definition you see, this is Monteggia fracture. This is Galeazzi fracture. You see, Monteggia, fracture upper third ulna, this is radius, this is ulna. This is radius, this is ulna. See, upper third ulna with dislocation of the radial head. This is Monteggia. Galeazzi fracture is fracture lower third radius with dislocation of the distal radio-ulnar joint. Okay, so this is Galeazzi fracture, and this goes by two other names. This is otherwise called Piedmont fracture. This is otherwise called fracture of necessity or reverse Monteggia, since it's opposite to Monteggia. See, already I told you a fracture of necessity. That fracture of necessity we had seen in lateral condyle fractures of humerus in a child. It's called a fracture of necessity, otherwise called Jupiter fracture. This is the second fracture of necessity. Whenever they use only two fractures of necessities are there in orthopedics. One is lateral condyle fracture in a child, another is a Galeazzi fracture in an adult. Why it's called fracture of necessity? As I told earlier, 100% surgery is necessary. So it's called fracture of necessity. It's called fracture of necessity.
Question 13. Which of the following is the most radiosensitive tumor? Here are the options. A. Ewing's sarcoma. B. Melanoma. C. Osteosarcoma. D. Renal cell carcinoma. And the correct answer is A. Ewing's sarcoma. Here's the explanation.
Ewing's sarcoma, they will try to fool us because this is one tumor. Ewing's sarcoma is one tumor, highly radiosensitive. So far we have never seen any bone tumor this highly radiosensitive. It's highly radiosensitive. Okay, this is radiosensitive, right? Highly radiosensitive. So some books uses a word, it melts like a snow. Okay, Ewing's sarcoma, when you give radiation, when sun comes, what happens to the snow? It melts and goes. No, like that when you give radiation, Ewing's sarcoma will go away, melts like a snow. That's what many books says, that melts like a snow. That's true.
Question 14. A young male patient sustained a right tibial shaft fracture following a road traffic accident. The patient's right leg was immobilized with a plaster cast. This patient now presents to the emergency with severe pain in the leg. On examination, the distal pulses are absent, on passive stretching the pain increases, and on opening the plaster, the right leg appears edematous and numerous blisters are seen. Considering the suspected diagnosis, what would be the most appropriate management in this case? Here are the options. A. Fasciotomy. B. Elevation of limb. C. Opening of the plaster is sufficient. D. Closed reduction. And the correct answer is A. Fasciotomy. Here's the explanation.
The treatment of choice for acute compartment syndrome is emergency fasciotomy. Don't think fasciotomy a very heroic procedure. It needs MS ortho to do that. No, it's an intern procedure. Okay, it is a house officer's procedure. What is that? Just in the flexor compartment of the forearm, take a 22 blade, just give a deep nick. Put a nick, put an incision, skin subcutaneous tissue, just put a nick in the deep fascia. Okay, all the pressure is released equally and the intracompartmental pressure will come down. What happens? What is the problem in raised intracompartmental pressure? When pressure rises, that pressure is compressing the vessel and vessel is causing more necrosis to the muscle. That's what. Okay, so when you intervene in early stage, when you release the pressure, the blood supply to that particular muscle is not affected, and from Oakman's ischemia, it will not proceed to Oakman's ischemic contracture. Only if necrosis happens, it's an irreversible damage. Okay, so emergency fasciotomy, it should be done immediately. What is emergency fasciotomy? Just taking a 22 blade, putting a skin subcutaneous tissue, and you are just incising the deep fascia. All the pressure will be let out, and just close the skin with a simple stitch, loose stitch. This is called emergency fascia.
Question 15. A young girl had thigh swelling with discharging sinus from which a bony fragment came out. The parents were concerned about what it was and asked the doctor. What is the term used for it? Here are the options. A. Sequestrum. B. Involucrum. C. Cloaca. D. Sinus tract. And the correct answer is A. Sequestrum. Here's the explanation.
Sequestrum means dead bone. The correct definition of sequestrum is dead bone within a living bone. Look at this diagram. See, this is a living bone. Inside you are able to see a dead bone, like a nidus. So, this is called sequestrum. This is called sequestrum. In Latin, sequestra. Sequestra means stand apart, stand alone, stand apart. So, alone. Okay. So, it's getting separated from the living bone. It's alone. That's the meaning of sequestra, literal meaning of sequestra. So, define a sequestrum, dead bone inside a living bone. That's called a sequestrum. Okay, that is main source of infection because it's dead bone. In X-ray, this is seen as a radio-opaque structure. Seen as a radio-opaque structure. That's called a sequestrum.
Question 16. Postmenopausal women fall down in the washroom. The X-ray is given below. Which of the most common fracture she will suffer? Here are the options. A. Colles fracture. B. Montagia fracture. C. Smith fracture. D. Galeazzi fracture. And the correct answer is A. Colles fracture. Here's the explanation.
Colles fracture. Okay. So, probably the most favorite fracture of undergraduates, all of us, we are very familiar with Colles fracture. Very often asked MCQ area. First of all, okay, Colles fracture, it's named after Sir Abraham Colles. Okay. Named after Sir Abraham Colles. Okay, Sir Abraham Colles. But he didn't call this fracture Colles. The original name he used was Potthaus fracture. So, Colles fracture was originally it was named by Sir Abraham Colles as Potthaus fracture. Only after the demise of the great Sir Abraham Colles, we are calling that as Colles fracture. The definition of Colles fracture is very important. It is not just a simple fracture, it's a fracture dislocation. So, you concentrate on the definition. It's not just a fracture lower end of radius, but a fracture dislocation of the distal radioulnar joint. The fracture occurs about 2.5 centimeters above the carpal extremity of the radius. So, it occurs 2.5 centimeters above the carpal extremity of the radius. So, it says very clearly it is extra-articular. Extra-articular. Okay. Whereas Barton, it's intra-articular. This is extra-articular. So, fracture happens at cortico-cancellous junction. This is the most common fracture in older age. Overall, the most common fracture of elderly individual is Colles, Colles, Colles. I repeat once again, most common fracture of newborn is clavicle, most common fracture of children is supracondylar, most common fracture of young adults is scaphoid, most common fracture of elderly is Colles. Most common joint to get dislocated is shoulder, most common dislocation happening in children is elbow. Okay, yes. And the mechanism of action, mechanism of injury, what's the mechanism of injury? Look at this diagram, it is fall on outstretched hand, there is no doubt, F-O-O-S-H, FOOSH, fall on outstretched hand. Fall on outstretched hand in a pronated dorsiflexed hand, that's the point. The exact mechanism is pronated dorsiflexed hand, okay. So, it is FOOSH, there is no doubt, it is fall on outstretched hand and the forearm should be pronated and the hand should be dorsiflexed. So, look at this diagram classically. So, Colles fracture will happen here. Colles fracture will happen.
Question 17. A 6-year-old child is suspected with a supracondylar fracture of the right hand, complaining of pain and swelling. X-ray of the right elbow was not significant. What is the next best step in this case? Here are the options. A. Compare with X-ray of left hand. B. Closed reduction and slab. C. Closed reduction with K-wire fixation cast. D. Cast. And the correct answer is B. Closed reduction and slab. Here's the explanation.
Treatment. As I said earlier, always in orthopedics, especially traumatology, treatment is based on the classification. And in our exam NEET PG, very clearly they are asking the question. Type 1, what is the treatment of choice? Type 2, what is the treatment of choice? Like that. So very simple. Type 1, treatment of choice is conservative, conservative, conservative. That means no surgery. Type 1, as I said, Gottland's type 1. There is a thin fracture line, hairline fracture line, which runs between anterior and posterior cortex, and both the cortex are not displaced. That is type 1. You see, in type 1, what happens? No, type 1, what is the best treatment you can do? Immobilization in a long arm cast at 60 to 110 degree flexion, and you should maintain that for 3 weeks. So look at that. So you are just maintaining in a flexed elbow. See, this is the supracondylar fracture. This is the supracondylar fracture. Okay. So you are in a long arm cast from the insertion of the deltoid till your wrist here. You are putting a long arm cast. You are immobilizing the elbow in, this is 110 degree, like the 60 to 110 degree. When I flex like this, the triceps will act like a splint, and it will prevent further disturbance of the fracture site. It acts as an internal splint, and your fracture will heal in a period of 3 to 4 weeks maximum. Okay, that is the treatment of choice. Type 1, it is immobilization in a long arm cast in 110 degree flexion. That is the treatment of choice. And in that there is a rule actually. Medial and lateral tilt is corrected first and posterior displacement next. Okay. So I said the most common type is posteromedial. So you correct the medial first, correct the posterior next. That will give a good reduction. Right.
Question 18. 3-point bony relationship has diagnostic value in. Here are the options. A. Elbow fracture. B. Montague fracture. C. Galeazzi fracture. D. Colles fracture. And the correct answer is A. Elbow fracture. Here's the explanation.
The 3 bony prominences are altered. 3 bony prominences are altered. I am telling you several times, the 3 bony prominences, very important thing. There is a lateral epicondyle, a medial epicondyle, Olecranon. When you see it's a supracondylar fracture, this is well maintained. This is well maintained because it's happening, fracture is happening above the elbow. So it's maintained. If it is an elbow dislocation, the whole triangle is altered. Okay, you see, in supracondylar fracture, the triangle is maintained. In case of elbow dislocation, totally it is disturbed. That's the second.
Question 19. Management of Olecranon fracture as seen in the images. Here are the options. A. Above elbow plaster slab. B. Below elbow plaster slab. C. Close reduction with tension band wiring. D. Open reduction with tension band wiring. And the correct answer is D. Open reduction with tension band wiring. Here's the explanation.
One more peculiar thing about this fracture, X-ray will always cheat us because it will show you a small lateral condylar chip in the thing. When you open and see, definitely the chip will be bigger one than you had visualized in the X-ray. Why that's happening? Because the fragment which is showing is cartilaginous. It's not fully formed bone, it's cartilaginous. So cartilages are not seen well in the X-ray. So X-ray will always cheat us. X-ray will show you a small chip. You may be thinking it's a small chunk. When you really open it, you will see the fragment will be really bigger in size. That's why X-ray will give you the fracture, will tell you there is a fracture. But with that X-ray, you can't plan. Okay. So treatment is always open reduction and internal fixation with the K-wire. Okay, so treatment is 100% surgery. That is why it's called fracture of necessity. That's why it's called fracture of necessity. Okay, so this is about, and what are the
Question 20. Involvement of deep PIP and sparing of MCP and wrist is seen in. Here are the options. A. Osteoarthritis. B. Rheumatoid arthritis. C. Psoriasis. D. Hyperparathyroidism. And the correct answer is A. Osteoarthritis. Here's the explanation.
increased stress is the most common precursor of primary osteoarthritis. That stress can be because of obesity, that stress can be because of overusage of the joint. Okay, so increased stress is the most common cause. Earliest symptom, everyone knows it's pain, and the most distressing symptom is loss of function. Is loss of function. Joint is not able to flex or extend. What is the use of a joint? So the earliest symptom is pain. Most common distressing symptom is loss of function. Okay, and you see the clinical manifestation apart from patient, when they get, you will get the joint congruity is lost, so the patient can get a genu varum, bow leg. Rarely patient can get a genu valgum. Okay, genu valgum is more common in rheumatoid. Genu varum is more common in osteoarthritis. Okay, and in the hand, when you see, are you able to see a bulge here? This is proximal interphalanges here, and you are able to see a small bulge here, the distal interphalangeal joint. So you see a bulge in the proximal interphalangeal joint. This is called Bouchard's node. This is called Bouchard's node. Bouchard's nodule. Okay, Bouchard's nodule. A bulge in the distal interphalangeal joint is called Herberdon's nodule. Herberdon's nodule. 1 lakh time repeated MCQ. So whenever you see, this is an image based question, definitely this will come. They will give this. What could be the probable diagnosis? They may ask a question. We think, hand means is it rheumatoid? No. Rheumatoid, already we had seen, it will never involve the distal interphalangeal joint. So whenever there is a swelling in the distal interphalangeal joint, that's called Herberdon's nodule. Any involvement of the proximal interphalangeal joint is called Bouchard's nodule. So this is a hand sign of osteoarthritis. Bouchard's nodule, Herberdon's nodule. Several times repeated.
Question 21. 79 YRS old lady had fall. The following X-ray was taken. Which of the following is the treatment? Here are the options. A. Hemiarthroplasty. B. Hip spica. C. Total hip replacement. D. Nailing. And the correct answer is A. Hemiarthroplasty. Here's the explanation.
Okay, prosthetic replacement, joint replacement is of two types. One is called hemiarthroplasty. Another is called total hip replacement. Okay, one is hemiarthroplasty. Okay, another is called total hip replacement. When I will do hemiarthroplasty, when I will opt for total hip replacement. See, fracture neck of femur has happened. Fracture neck of femur means only the head will go for avascular necrosis. So, hemiarthroplasty means replacing the head neck alone. It's called hemiarthroplasty. I am not touching the acetabulum. That's called hemiarthroplasty. If I am changing the acetabulum also, that is called total hip replacement. I repeat once again, when I replace only the head and neck, it is called hemiarthroplasty. When I replace acetabulum also, that is called total hip replacement. So when I will do a hemiarthroplasty, when I will do a total hip replacement, the main factor is status of the acetabulum. The main thing is your status of the acetabulum. If acetabulum is also damaged, no other option, I should go for total hip replacement. You just think, guys, you see, if acetabulum, for example, can be damaged in two situations, fracture neck of femur, along with that the patient has developed fracture acetabulum also. What will happen if otherwise, next way, how an acetabulum can get affected? A degenerative changes in the acetabulum. That's called osteoarthritis. Degenerative changes of the acetabulum. See, what will happen if I just in that situation, if acetabulum is damaged, if I change only the head and neck, what will happen? The processes will go and rub against the acetabulum. Won't it cause pain? Definitely. Severe pain. See, patient, you are replacing the head and neck. What is the very purpose of doing surgery in orthopedics? Pain-free mobile life. It should be pain-free. Patient should be moving. Okay, that is the essence of orthopedics. Essence of mobility is life. Patient should move. He should move comfortably without pain. So if acetabulum is damaged, when you change head and neck alone, patient can walk, but he will limp because of pain. So you have to replace the acetabulum also. So when to do for total hip replacement? If the patient is having a fractured neck of femur with a damaged acetabulum, I have to go directly for total hip replacement. If the other scenario, acetabulum is intact, not at all affected, only head has gone for avascular necrosis, you are expecting that head will go for avascular necrosis. I want to change only the head and neck of the individual, and that is called hemiarthroplasty. So, putting in a nutshell, if it is type 3 or type 4 gardens, straight away I should plan for arthroplasty. I will decide arthroplasty depending upon age of the individual and the acetabular status. If the age of the individual is above 60 years or below 60 years, acetabulum is fine, I will try hemiarthroplasty. If acetabulum is damaged, no question about age, I will go for total hip.
Question 22. 8-year-old boy sustained a fracture to the hand while playing with his sister. In which of the following condition, the triangular relation of the elbow is maintained? Here are the options. A. Fracture ulna. B. Anterior dislocation of elbow. C. Posterior dislocation of elbow. D. Supracondylar fracture of humerus. And the correct answer is D. Supracondylar fracture of humerus. Here's the explanation.
The important point is, the third point, it is 3 bony points are maintained. Three bony points are maintained. What are the 3 bony points? It forms an triangle, an inverted triangle. 3 bony points are maintained. What's the meaning? This is medial epicondyle. This is lateral epicondyle. This is olecranon. Just you see, this is humerus. Fracture is above these condyles. Fracture line runs above the condyle. That's why it's called supracondylar. So when you just frame a triangle, when you say flex the elbow, it forms an inverted triangle, an isosceles triangle like this. Medial epicondyle, lateral epicondyle, olecranon. It forms a triangle like this, and this triangle is well maintained if it's a supracondylar fracture. Suppose the same thing is an elbow dislocation, which we are going to see the next topic. Elbow dislocation, totally this triangle is altered. So that is the difference. So in an MCQ, in a clinically based question, they say the 3 bony points are not maintained. Then it is not supracondylar fracture. That could be an elbow dislocation or some other lateral condyle fracture. The next topic I'll teach you that. So if it is a supracondylar fracture, the 3 bony points should be well maintained. It should be well.
Question 23. Most common site of osteomyelitis in children. Here are the options. A. Diaphysis. B. Metaphysis. C. Epiphysis. D. Growth plate. And the correct answer is B. Metaphysis. Here's the explanation.
The bone has an epiphysis, a metaphysis, and a diaphysis. Osteomyelitis is a disorder of metaphysis. Most common part of bone to be affected, whether a child or adult, it is the metaphysis. And you should.
Question 24. With respect to tuberculosis of the hip, which of the marked areas are affected commonly? Here are the options. A. 3. B. 2. C. 1. D. 4. And the correct answer is C. 1. Here's the explanation.
Lesion in hip starts in any of the following area. Number 1, it can be, dear friends, you mark here, it can be in the acetabular roof. Okay, this is number 1, can be in the acetabular roof. Number 2, it can be in the epiphysis of the, look at here, epiphysis of the, this can be the second site, epiphysis of the femoral head. Number 3, it can be in metaphysis of the femoral neck. This is the neck, metaphysis of the femoral neck, and this is called Babcock's triangle. This area is called Babcock's triangle. That's the third side. Fourth, it can be in the greater trochanter. Last but not the least, it can be in the synovium. Okay, so these are the 5 sites tuberculosis of hip can start. Mostly, this is in the order. That's why the first site of affection, if they ask it, the answer is acetabular roof. Answer is acetabular roof. Okay. Book says at the end it will affect the synovium. In knee joint, it reverses. The very common site or the first site to get affected is synovium. In hip, the first site of affection is acetabular roof. Second site is
Question 25. Football player with knee injury diagnosed as medial collateral ligament injury. Which structure is most commonly associated with this type of injury? Here are the options. A. Anterior cruciate ligament. B. Medial meniscus. C. Posterior cruciate ligament. D. Lateral lemniscus. And the correct answer is B. Medial meniscus. Here's the explanation.
the medial meniscus is more prone for injury than lateral meniscus. Among the two cruciate, ACL is more prone for injury. The reason you know, it is thinner. Okay, it is not, and it is weaker than PCL. So it's more prone for injury. Okay. Here, medial meniscus is more prone for injury because it is very firmly attached to the medial collateral ligament and joint capsule. It's very tight and it's very firmly attached to the medial collateral ligament and the joint capsule. So it is more prone for injury. Lateral meniscus is not that firmly attached. So some injury happens. No, it's not very tightly attached. So it is less prone for injury. So medial meniscus is more prone for injury because it is firmly attached to the medial collateral ligament and the joint capsule.
Join us for a quick PYQ mock session on pediatrics tomorrow. Like and subscribe if you learned something new today. See you in the next one.